My name is Dr. Idris. Today I'm going to present the management of ureteric and bladder stone, and in this ureterorenoscopy and cystolitholipexy. First of all, ureteroscopy. Ureteroscopy is also known as ureterorenoscopy, is a procedure in which ureteroscope is passed through the urethra and bladder into the ureter to diagnose and treat the urinary tract problems. The ureteroscopy indications are for the diagnostic as well as therapeutic purpose. For diagnostic, when there is benign hematuria, positive cytology, and negative cystoscopy, and when there is filling defect in excretory urography, recurrent UTI. For therapeutic purpose, and when there is ureteric stone, ureterolithiasis, upper tract TCC, pelvic-ureteric junction obstruction, or ureteric stricture, and for the removal of foreign body, suture, migrated ureteral stents, balloon catheter, and fracture instruments. For preoperative preparation, we have to take detailed history, examination, and investigations. We do ultrasound, X-ray to diagnose the stone, and IVP, and retrograde pylography, in which intravenous contrast agent can't be given, and abdominal helical CT scan is done. And we have to stop anticoagulant 7 to 10 days before the operation. And if there is UTI, we should be treated. And preoperative antibiotic if there is parenchymal reflex or traumatic procedure. After that we have to decide for the anesthesia. For proximal ureteric stone, we give general anesthesia, and for distal ureteric stone, spinal anesthesia is given. And in the female patient, intravenous analgesia has shown to be sufficient for distal ureteric stone.
Okay, there are three scenarios rather we commonly meet in the preoperative preparation: hypertension, diabetes, and patient with epilepsy, history of epilepsy. So, Fahd, tell me, what are the preoperative preparations for a patient with hypertension, diabetes, and epilepsies if he is going for a URS the next day? So this is a very common scenario, and
Sir, for diabetic patient, diabetic control should be done. Ideally, as we in our ward, we cut off our fasting blood sugar 140, and for hypertensive patient, antihypertensive should be taken.
okay.
And
So,
systolic.
in what do you for diabetic patients? He has been optimized by the diabetic team, and what do you do in the on the morning of the surgery with the diabetic patients?
Sir, if the patient is on insulin, we should omit the dose of insulin, and on oral hypoglycemic, we will not give oral hypoglycemic.
So we omit the morning dose of oral hypoglycemics and note the fasting sugar. What about hypertension?
Sir, hypertension, we give the dose of antihypertensive.
With a sip of water. And what about the patient with epilepsy?
Sir, epilepsy, if the neurologist had advised IV, we should load the patient 1 hour before the surgery, or if there is oral anti-epileptic, we should give anti-epileptic drug.
Okay, so now post-operative care is a little extended out of the presentation. So next, continue, please.
Now the patient position. Patient position is very important for ureteroscopy. Mostly lithotomy position. Patient is placed in lithotomy position, and in flexible URS, supine and lateral decubitus position can be used.
Okay, now from Sakkar, Dr. Nazish and Dr. You are going to appear in the talks. Tell me what when you are going for URS, what will be present on your table of ureteroscopy table?
Sir, fluoroscope, and along with that, the ureterorenoscope, flexible if possible. The position of the for the position of the patient, the hand.
The patient will not be on the instrument table. What is going to be on the instrument table, and why a flexible URS on the first account?
Okay. So instrument table, the ureterorenoscope. For adults, it could be 8 8 FR and 8/9.8 FR and 6.6/7.6 FR ureterinoscope, rigid, semi-rigid. And we don't have a flexible ureterinoscope, but if it is available, then it will be good. And along with that, for the irrigation, for not for the hand pump, for the to give the मतलब प्रेशर ऑफ द वाटर के लिए आपके पास होना चाहिए जो है इसका हैंड पंप और जो पंप का सिस्टम होता है, प्रेशर का सिस्टम होता है, वो होना चाहिए। फ्लोरोस्कोप होना चाहिए आपके पास, और इसके अलावा आपके पास लिथोक्लास्ट होना चाहिए, न्यूमेटिक लिथोक्लास्ट से अगर आप सेमी रिजिड से कर रहे हैं, और एनर्जाइजिंग पावर होनी चाहिए उसके लिए आपके पास टॉवर होना चाहिए।
चलें आगे
कैथेटर होगा आपको फॉर दी एक्सेस शीट के लिए कि आप वहां से एक्सेस करें। गाइड वायर होनी चाहिए आपके पास फॉर द थिंग कि अगर किसी किस्म का इंडिकेशन बनती है टू पुट द डीजे स्टैंड और नॉट द डीजे स्टैंड, तो आपके पास डीजे स्टैंड होना चाहिए।
ठीक।
Ureteroscopy instruments: cystoscope, ureteroscope, saline for irrigation, guide wire, glide wire, ureteric catheter, ureteral dilatation, sheath, trolley, fluoroscope, C-arm, contrast agent, and energy are 4 types: lithoclast, laser, electrohydraulic lithotripsy, and ultrasound. Ureteroscope. There are 4 types of ureteroscope: rigid, semi-rigid, flexible, and digital ureteroscope. First of all, rigid ureteroscope. They have large diameter and large rod lengths, not used these days. And the semi-rigid ureteroscope use fiber optical system. The diameter is 4.5/6 FR, 6/7.5 FR, 8/9.8 FR, and the working channel is 3 to 6 FR. Flexible ureteroscope. They also work on the fiber optic system, and the deflection is from 120 to 170 degree, and the working channel is 3.6 FR to 4 FR, and the tip size is 6.5 to 9 FR. These are the standard flexible ureteroscope. They have deflection up to 170 degree, and there are some modernized semi-flexible ureteroscope. They have deflection up to 325 degree. This is a digital ureteroscope in which there is light source is present on the tip of the ureteroscope. Now, guide wires. Guide wires are used for the ureteric access, straightening of the ureter, dilatation of the ureter, and for making the percutaneous tract and stent placement. Guide wires are working wires or safety wires, lubricious wires, also called glide wires, and the stiffer wires, they are used for the stent placement or ureteral access sheath placement.
6 FR or 5 size.
Guide wire using in URS. Anyone else? Numan, bata देते।
We use the guidelines of 0.035
Okay.
or 0.018 the limit.
Okay, and there's a glide wire as well.
The glide wire it is hydrophilic and lubricatious. It is used for guiding us to pass the kink. If there is any if we cannot manipulate the glide or there is obstruction distally, we use the glide wire. It is very soft and malleable. It cannot rupture or cause iatrogenic injury mostly because it is very soft.
Any classification based on the tip of the guide wire?
It's J tip. It is straight. But tip is always soft.
So your knowledge of guide wires is very important when you come to doing the intervention with the URS. So these all should be in your knowledge. Okay, please continue.
Now, ureteric catheters. Ureteric catheter are mostly from 4 to 6 FR open-ended ureteral catheter. They are used for exchange wires, installation of dye, and dual lumen catheters, and post-procedure for the drainage. Now, ureteral dilatation devices. They are active dilatation and the passive dilatation. For active dilation, progressively increasing caliber catheter or balloon use. For passive dilatation, ureteral stenting is done 3 to 7 days before definite surgery. And the types of ureteral dilatations are metallic dilators, sequential dilator, balloon dilator, and stenting. Now, intracorporeal lithotripter. There are 4 types: electrohydraulic, ultrasonic, and pneumatic, and laser. First is electrohydraulic lithotripsy. And they are cost effective and can be used with both rigid and flexible ureteroscope. The disadvantage of this is damage to ureteral mucosa and associated with ureteral perforation. Ultrasonic lithotripsy use ultrasonic energy, and it is safe, efficient, and controlled destruction of the stone and stone fragmentation and extraction via probe channel. Pneumatic lithotripsy, in which electromechanical energy is used, good fragmentation of the stone, and low risk of ureteral injury. And there is significant stone retropulsion in pneumatic lithotripsy. Now, laser lithotripsy, it is light amplification by stimulation of emission of radiation. And it is safe. Flexible quartz fibers can be used with both rigid and flexible ureteroscope, and effective for any composition of stone, and disadvantage is cost effect. Laser-based treatment. Laser-based treatment is ND-YAG and Holmian YAG. 365 micrometer fibers can be used in semi-rigid, and 220 microfibers is used in flexible scope. ND-YAG lasers are low cost of ND-YAG, and efficacy is low for hard stone, calcium oxalate, monohydrate, and cystine stone. Holmium YAG is gold standard and disintegrate all chemical stone composition, and mechanism is thermal decomposition of the stone and thermal expansion of vaporization of water.
No, I just wanted to know that, can you please elaborate what are the different mechanism of all these lithotripters? You were just saying that electrohydraulic, pneumatic, laser, and ultrasonic. So how does all these energy perform differently? And what is the reason that there is more trauma to ureter with electrohydraulic lithotripters?
So we can get some person who is about to appear in the exam. Anyone? How does the electrohydraulic work and how does the pneumoglass work? What is the difference? And then we'll be talking about lasers. Anyone from Sakkar? A question from Sakkar to Sakkar.
Yes, Kalimullah.
Yes, sir. Sir, first of all, the ultrasonic and electrohydraulic, the ultrasonic have, I think, hammer effect, and the laser have vaporization effect. I don't know about electrohydraulic.
You need to think better because exam is on your head now. Anyone else?
Sir, I know about pneumatic and laser. In the pneumatic lithotrap, we had a pad under our foot, and in which we push on the pad. There is the air which is pumped towards the probe, and probe is just like the hammer. It lithoglass the stone, and it can also cause the ureteric damage if it is on the mucosa, but it can also cause the stone pushback or repulsion because it is hammer effect, and there is nothing behind the stone. And about the laser, and for the laser we have a laser fiber, and laser is produced by the specific laser machine. For example, if we have a holmium or yak, these are different kind of lasers. They have 2 or 3 mechanism: dusting, bus, or fragmentation according to the power and frequency. So and ultrasonic, seen only for once and never did. Electrohydraulic.
जी नादिश, आप कुछ कहना चाह रहे हैं?
सर अल्ट्रासोनिक के लिए जो शॉक वेव जस्ट लाइक ESWL में होती हैं, उसी तरह के लिए यहाँ पर भी जनरेट होती हैं, जो कि इलेक्ट्रोहाइड्रोलिक हाइड्रोलिक होता है। तो उसमें जो मैकेनिज्म आता है वो जो एक स्पार्क फाइबर होता है, वहां पे जाके जब वो हिट करता है उसके थ्रू एनर्जी जनरेट होती है, तो इलेक्ट्रोहाइड्रोलिक होता है, जिसकी वजह से परफोरेशन ज्यादा होती है, रिट्रोपल्जन कम होती है। न्यूमेटिक में जो है वो परफोरेशन के चांसेस कम होते हैं, लेकिन रिट्रोपल्जन के ज्यादा होते हैं बिकॉज ऑफ इट्स जैक हैमर इफेक्ट।
was talking about the laser effect. The next slide.
Laser has dusting, fragmentation, and popcorn effect. For dusting, long pulse, low energy and high frequency is used, and for fragmentation, short pulse, high energy and low frequency is used. And popcorn, there is long pulse, high energy and high frequency is used. And Holmian bag, low tissue perforation, low tissue penetration of less than 0.5 mm, few thermal injury, less stone migration than ballistic probe. Laser probe must have to contact to stone surface. Perforation of ureteral and pelvic wall is possible. Now the ureteral occluding devices. Stone cone 2.2F, and they are used to prevent the stone retropulsion, and these are placed proximal to the stone before the fragmentation, and it is made of netinolol stainless steel wires. And second one is end trap. It is made up of tightly woven netinolol fiber displaced through 3FR catheter and placed proximal to the calculi, functioning as backstop, and it also prevents the stone retropulsion. Accordion, it has 2-part nylon and stainless steel guide wires with short length of polyurethane film attached to the wire section form a bottle brush-like obstruction within the ureter lumen, preventing stone retropulsion. And this is a video description of the ureteral occluding device. First, the occluding device is placed proximal to the stone, and then stone is fragmented, and after that, stone is extracted through the ureter. And last is ureteral occluding device is Urogel in which thermosensitive polymers is used, which solid at body temperature and liquid at cooler temperature. It is placed proximal to the stone through 3FR catheter and temporarily occlude the ureter, preventing proximal migration. After lithotripsy, polymer resolution occur by irrigation with Kohler saline.
I'd like to ask Nazish, if what in sucker, how do you prevent retropulsion when you're doing URS? Are there any maneuvers that you do there as well?
There is only like head up करते हैं। दूसरा ये कि वाटर चैनल जो है आपको वाटर पे आपको कम रखना होता है। दूसरी चीज ये है कि जब स्टोन को पास कर जाते हैं तो विद वाटर प्रेशर के थ्रू आप बाहर वापस आ जाते हैं, लाइक साइफन इफेक्ट। तो उसके बाद आप जितने भी फ्रेगमेंटेड स्टोन है वो पास हो जाते हैं, लाइक देयर इज नो एनी अदर थिंग थ्रू व्हिच वी कैन prevent the retropulsion in Sakkar.
So whether you are in Sakkar or in Karachi, there is one more thing that you can do, and that is this jelly, which you are using for many purposes. So if you inject a little bit of jelly, that would form a kind of bubble around the stone, and the stone would be hanging within the bubble. It will not be retropulsed up to a certain extent. So whenever you have got no technological device available, you can always make use of the xylocaine jelly. So there is this paper from our country also about this usage of jelly. It was from Dr. Hamad Athar. So I think it is something which is very, very cost effective. Everybody should do it rather than retropulse the stone and then subject the same stone for lithotripsy. That is rather odd because you are combining two procedures for one thing. And if you are working in an environment where everything would be calculated according to the cost, then the cost would become double. You are doing two procedures for one stone. That is not on.
Right.
Now, stone retrieval device. They are stainless steel basket and natinolone basket, in which in natinolone it is tipless and with the tip. Tipless prevent the ureteric injury. Complication of the ureteroscopic basketing. It will lead to avulsion of the ureter, interception, abrasion of the ureter, perforation, post-operative stricture, and basket breakage or entrapment. Endo-irrigation system. Endo-irrigation system in which used for the dilatation of the ureter and improve vision during the procedure. It is done by active hand pump, Pathfinder bulb, and single action pump syringe, and by pressure irrigation, in which pressure is up to 300 mmHg. Fluoroscope equipment, in which C-arm is used and C-arm monitor is used. These are used for the ureteral access monitoring during endoscopy and stent placement, and it has greater mobility and improved image and less scattering of radiation exposure to the surgeon. This is a setup in which the video and C-arm monitor are on one side along with irrigation, light source, and lithotrite generator, and C-arm is placed on the other side. For ureteroscope, scopy, the steps are, first of all, cystoscopy is introduced through the urethra into the bladder by applying xylocaine gel on the cystoscope, and after that identification of the ureteric orifice is done. Then ureteric catheter pass up to the respective ureter that is to be cannulated, and guide wire is pass up to the collecting system of the respective kidney, and ureteral catheter is ascend over it, and guide wire is replaced with guide wire, and introduction of the instrument is URS, and pressure of the fluid should be managed that prevent retropulsion, and the lithoclast is introduced through the ureteroscope channel, and fragmentation of the stone is done. And as already described, the retropulsion devices we should avoid retropulsion, and we use instrument for retrieval of the stone. And after that, the question is arise whether we should place DJ or not. In high risk cases, DJ is placed in ureteral injury, high chances when there is chances of edema and strictures large residual stone burden, solitary kidney, renal insufficiency, and coagulopathy. For ureteral edema, 2 to 3 stent is placed for 2 to 3 days, and for ureteral injury, stent is placed for 4 to 6 weeks. And techniques in the steps. For distal and the mid-ureteric stone, semi-rigid ureteroscope is used. If the stone size is greater than 4 mm, holmium razor lithotripsy is used. If the stone size is less than 4 mm, the stone is easily removed with basket or grasper. For proximal ureteric stone, flexible ureteroscope is used. And the complications, there is an intraoperative complication and late complication. Intraoperative complication, there is bleeding, mucosal injury, false passage, thermal injury, there is ureteral perforation, submucosal or lost stone, there is ureteral avulsion and technology failure. Late complication is renal damage, ureteral stent discomfort, infection, sepsis, VUR, and ureteral stricture, and needs secondary treatment. After that, post-operative care, care of the anesthetized patient. It is a daycare procedure, and patient is mobilized and orally allowed when fully awake, and catheter can be removed. On discharge, the patient is advised for oral analgesic along with anticholinergic for the bladder spasm. Alpha adrenergic blockers are advised, and counsel about the stent placement and removal and stent related pain, and also give the date of stent removal if stent is placed. Now, flexible fiber optic ureteroscope, in which there is light source is present on the tip of the ureteroscope. This is a digital ureteroscope, in which there is also light source on the present on the tip of the ureteroscope, and we can also record the video from this. Deflection of the tip, and in which there is lever system connected to the deflection tip by wires, and the deflection is from 180 to 270 degree. It is uniplanar. Rotate the scope to achieve the deflection in different plane. Direction of the movement is intuitive and counterintuitive. Should be guided by fluoroscopy. And this is an exaggerated active deflection of flexible ureteroscope. And the precaution while using the deflection mechanism are failure of the deflection mechanism is most common cause of scope dysfunction. Scope should not be deflected while inserting laser fiber. Laser fiber scrape the inner surface of the working channel and create small rent which increase over the time and eventually perforate. And the golden rule, do not step on the pedal if you can't see the tip of the fiber in contact with the stone. Now, dilator and access sheath. Use of access sheath is optional during RIRS. It depends upon the stone load, pelvic axial system anatomy. The sizes is 9/11 FR and 12/14 FR. It facilitates introduction of the instrument within the endoscope and minimize the distal ureteric trauma, avoid the build-up of pressure within the pelvic axial system. The disadvantages of access sheath is pre-stenting 2 to 4 week due to less spacious ureter and ureteral injury. This is a ureteral access sheath in which there is 2 working channel, and it has hydrophilic coating, prevent the ureteric injury.
Before we go on to litholipexy, just a take-home message for all the residents. You see, there is a lot of armamentarium available that can augment the URS and can be used as adjunct. All these things should be in the back of your mind, and they all depend on case to case. Whatever adjunct instrument that you use to augment your URS procedure should be based on your case and the indication and the foresight that whatever procedure you can do has the potential to cause complication. You want to give cure and prevent injury. That is the concept.
Dr. Mazahir, what is your take on this ureteral access sheet? The advantage is that it will reduce the intrapelvic pressure, and the disadvantage, which we don't show or discuss, is that it damages the UO, ureteric orifice. So, what is your take on it? Should it be placed or not in every case, or what?
Sir, ureteral access sheet, it depends on case to case. If the advantages are there because of repeated insertion, there's less trauma to the ureter, decreases the intrapelvic pressure, the irrigation is better. But of course, the side effects are there that because of the size of the access sheet, there can be trauma due to insertion, damage to the ureteric orifice. But these are all dependent on case to case. Most people, they are fond of using the ureteric access sheet because of their practice. But we are here in SIUT, do not use it probably because of the cost effect. But it again depends on the effect of the case.
And after discussing with a lot of people, we realize that what we are doing over here is with the semi-rigid URS. And a lot of people around the world, for the pelvic stones, they use a semi-rigid, fragment that pelvic stone with a semi-rigid, and then for the calyceal stones or large fragments, when they have to remove it with a basket or anything, then they place it and it becomes easy to go in and out with the forceps to remove those large fragments as well. Because their objective is to make the patient stone free in an RIRS. So that gives an added advantage.
Regarding pre-standing, do we go for pre-standing in every patient, or it is just case to case?
Well,
we usually don't place this ureteral access sheet, but a lot of people say that pre-standing should be done. It is done 6 weeks before the procedure, that the ureter dilates and then we place it. So a lot of people do that.
Without prior placing of a DJ placement, it will compress the mucosa, and like Dr. Harris said that when you are doing RIRS, it may take hours, so it will compress the mucosa, it will cause a ischemic injury, and later on it will lead to the stricturing of the ureter. And this stricture segment usually very long, and you have to do something otherwise. So this cause ischemic injury to the mucosa and cause stricturing in the future. That's why pre-stenting is necessary in every case.
Yes, sir.
I suggest the post-operative stenting is also important for after placement of ureteral access sheath, because that can reduce the complications post-operatively.
Yes, sir. Rightly said.
Now, cystolitholipexy. Cystolitholipexy is a breakage of stone in the bladder into small pieces and remove them endoscopically. Different type of terminologies are used: cystolithopunch, perureteral cystolithoclast, in which perureteral breakage of the stone, and percutaneous suprapubic cystolithotomy, and combined endoscopic approach. Preoperative assessment is we have to take history, examination, and investigation, or ultrasound, X-ray, KUB, and cystoscopy. Rarely we use renovesical radiograph, IVU, retrograde cystography, or CT scan is required. After that, we had to decide for anesthesia fitness, and ECG is done. An instrument that used in cystolitholipexy are rigid cystoscope and flexible cystoscope. And the fragmentation is done by the pneumatic, ultrasonic, electrohydraulic, and laser lithotripter. and systolithal punch is also used. And anesthesia, general anesthesia, spinal anesthesia, and local anesthesia is used in flexible cystoscope with laser. Techniques or the steps in cystolithopexy. And the patient is position is patient is placed in lithotomy position. Cystouretheroscope is done to see the ureteral diameter, prostate lobes in male, and to see the bladder neck. And after that, if there is small stone burden, it should be lavaged with the scope or the sheath and extracted using forceps or fixation by resectoscope lumen. If there is voluminous stone, 200 ml of fluid is given in and stone fixed with cystoscope sheath and fragmented. And the complication of the cystolithopexy are malfunctioning of the instrument, mechanical lesion on the bladder mucosa, bladder perforation, hyponatremia, intraoperative bleeding, and UTI and ureteral strictures. And after that, the patient is on postoperative care should be given to the patient and orally allow and mobilize the patient, and on DC patient is given oral analgesic and alpha blockers. Thank you.